Is there any changes coming to the rest of the blocks today?
Say again?
Is there any changes coming to the rest of the blocks today?
What do you mean?
Are you updating anything else on this?
Not as far as I know. I can't run. Let me know if you want me to update on it, and I'll update it.
No, just meant like on the first thing I meant the switch.
Yeah, right now, the only thing that we're really kind of concerned about are, and when we get to it, I'll probably point it out, because I don't have the echo cartoons in there. I'm sure you guys remember those from farm. Most of the treatment, a lot of times we're going to use amphotericin B for a lot of this stuff. 3 different types of amphotericin B. And here we'll kind of delineate whether it's liposomal or not. Liposomal is the most commonly used just because it's the safest, got the safest side effect profile, much safer on kidney function. Penetrates a lot better, will be stable, more stable than standard amphotericin. And then there's amphotericin dioxylate, which is another type of amphotericin B. And we'll use that on only one of the disease processes that we'll talk about. But I'll just point those out to you just because as things change, some of the medication will change. Right? And understand that medicine is always changing. And we don't use that word very often in medicine. We don't use the word always very often. Medicine is always changing, which is one of the reasons why we will be lifelong learners once you guys finish here. You guys will still be learning. When I came through here, there were no echocardians. There were no direct-acting antivirals. There were no JAK inhibitors. So when I did pharmacology, I didn't have those, right? Those are all new things that have come out in the interim. So as we continue to learn, as we continue to read our journals, as we continue to go to our conferences, as we continue to talk to each other, as we continue to read pamphlets and handouts, and talk to some of the reps that come to your office, which is no longer authorized in the military, which used to be really cool when it was. We all continue to learn. So I will. So if you're in a private clinic, yes, football tickets. So I'll just kind of sort of point those out. If it's not on the slide deck, I probably won't test it. Okay, so remember, some of the things that I tell you is to make you a better provider. Okay? You can write those notes on the side if you like, but understand, I try to point some of those things out just so that you can be a better provider, which is one of the reasons why they like experienced people up here. So we can do a little bit of both, right? Teach about some of this stuff, and then we can add a little bit of experience to try to make you better once you get out there. All right? Any other questions before we start? No? Yes, maybe? All right. These have a bunch of questions too. The only difference between these questions and the last questions are that I actually put why it's the right answer and then why it's the wrong answers. Okay? Try to make it a little bit more educational if you read through those questions. All right, in campus. I don't have questions for the third block just because I figured you guys would be good by the time the third block roll around. Apparently I was mistaken. I have started working on some questions, so I may have some questions up for the third block. I may not. So if I have the bandwidth, I will try to put some questions up for the third block. All right. So mycotic disease basically means fungal type diseases. All right. Here's a whole bunch of the things that we're going to talk about. Okay, mycotic diseases, also known as fungal infections, have various types of fungus. Okay, they can affect a whole bunch of different things and a whole bunch of different body parts. Right? They can affect the skin, the nails, the lungs, any internal organ. Right? These first 4 that we're really going to talk about are all respiratory. You're going to inhale them, but once you inhale them, they're going to eventually become systemic. And once they become systemic, it's just going to go through your entire life. All right? That's just the way these things work. All right? And these aren't the common ones that you may be used to hearing fungal rise, right? Like athlete's foot, ringworm, candidiasis. The last one I will talk about will be candidiasis, but right, these are all fungal type infections. For this slide right here is pretty key, all right? A lot of these signs and symptoms are going to overlap with each other. Okay? They're all respiratory. Big difference between some of these are the way they affect you inside your lungs. We're going to keep the stuff inside the lungs kind of black box. Not going to open up that can of worms, right? Big reason why is because it goes into the subcells. Th1, beta C, hemagglutinin cells. It goes into a whole bunch of different cells. Just understand that once you inhale these things, it gets out to your cells, it affects your alveoli. Overall, it creates cytokines that come to its aid, right? Because that's what they do. And once they come to their aid, it causes a hyperinflammatory reaction. So once you get a hyperinflammatory reaction inside your lungs, it loosens and creates extra pressure everywhere. And when you get extra pressure everywhere inside your lungs start leaking stuff out. Right? So as you're leaking stuff out, okay, in some cases, it also creates cavitation, which is what we usually see in tuberculosis. If it does create cavitation, then you may also get blood in your lungs, and you may cough that up. But for the most part, at least for the first three, generally the increased inflammatory reaction inside the lung causes it to leak out. So you'll start having that difficulty breathing. All right. Now with these, they all have their little niches. Each one of these things has its own little niche. So when I give you a scenario, the scenario is going to place you within that niche. Okay? And that's not just me. When you go take your pants, it's going to be the same way, because that is the most common of where they're located. Okay? So geographical region, location is extremely important for mycotic diseases, because they are found in specific parts of the country and specific parts of the world, right? This is probably one of the first times you'll see race and ethnicity or nationality as part of, okay, where are they from? All right. The big ones are Filipinos and African Americans. And according to the studies, it says that there's a genetic issue where they don't deal very well with some of the mycotic diseases. Okay? So now we know that they are at risk population. And we'll talk through as we go through some of these. Why do I have hobbies on here? Anybody can tell? Splunking, yes. So when you see a cave, splunking hikers, you're welcome. That's a question that I wrote for the pants, right? And you'll realize that splunking is one of the areas where you can get infected with one of these diseases, right? So part of what you need to know is, what do these people do? Do they hike? Do they go camping? Were they sleeping next to a river or next to some decaying vegetation, right? As part of their hobby, because they were out camping someplace. Right? So hobbies is going to put you into a location, an activity that may put you around the area that can infect you. So it's kind of important, right? And then it all goes back to your HPI when you start asking these questions for these people, right? Where were you? What were you doing? Right? What kind of hobbies did you have? Did you drink any of the water out there? Right? And then of course, for all of these immunocompromised folks, neutropenic folks, folks with transplants, okay, they're all at high risk. Fungal infections are opportunistic infections. They will take over whenever they can. And if you're an immunocompromised or a neutropenic person, they're going to take advantage. That's what they do. Okay? So be aware of those guys. All right, so here's just some overall things for mycotic diseases there. We just talked about endemic. So within the United States and within the world, there's usually identifiable niches. Okay? They are endemic within certain parts of the country, and we'll talk about those. These four initially are ingested via your respiratory system, right? You breathe them in, right? Usually inhalation, pulmonary infection, and then dissemination, right? So once it causes your lungs to get jacked up, it'll eventually make it to your bloodstream, and it'll start circulating throughout your body, and then it'll start going everywhere. Skin, liver, kidneys, brain, cause you meningitis, a lot of bad stuff. Now, what you do need to know here is dimorphism. Okay? And dimorphism is their ability to live in two different forms. Okay? And that's important, especially when you're going to culture these things, right? So, dimorphism means when they're outside the body at a certain temperature, usually greater than 77 degrees, right? They live one way. They are what we call a mold. Okay, they have a nice shell outside and they're protected, right, until something picks them up. Once something picks them up, in our case, we inhale them as we pick them up. It gets into our lungs and it starts going down to body temperature. It starts going up to body temperature, right, 98.6. Most of these things turn into yeast once they get into our body at that specific temperature, body temperature for us, right? And it takes a little while for it to grow, right? But nevertheless, we inhaled it as a mold, but it turns into yeast as it goes into our body. Right? So when we push that out to the lab uses that. Now, some of these are extremely infectious. Right? If it is extremely infectious, you got to be careful. They need to be aware, right? Because these are respiratory problems, and they need to know so that they can put it at the appropriate bio level. Some of these should be at bio level 3 or 4 because of their infectivity. Okay. Coccidiomycosis, that one says it has spherules, so it's a little bit different. Okay. The regular ones that we'll talk about usually inhale the mold and it turns into yeast. This one has what we call an orthochondria, a little barrel-shaped thing. That's the way it lives outside in the environment. Okay, they're microns in size. You can't even see them, right? So as they get kicked up, wind blows it, you inhale it, that orthochondria breaks up and causes, as it continues to break open from the heat, it causes spherules, and within those spherules there's endospores. And as it continues to get hotter and hotter inside the body, they develop, those endospores rupture inside your lungs and continue to make more. Okay? And it continues to make your lungs worse. That's the difference between the regular molds and then the way the spherules work for coccidiomycosis. Okay? The nice thing about these, you can see there is no evidence of transmission among humans or animals. Right? So humans and or animals can get any of these fungal respiratory issues. Okay? All right, the first one we're going to talk about is blasto. So look at the locations. Okay, border the Mississippi and Ohio rivers, Midwestern states, Canadian provinces bordering the Great Lakes, New York, Canada, St. Lawrence River, and male prevalence. All right, so understand the location of where usually you'll find this blastomycosis. Usually caused by blastomyces dermatitidis. Okay? And as you see that second part, blastomyces dermatitidis, right? That means that it may also have a skin component. We'll talk about that here in a bit, but just looking at the word overall, blastomyces dermatitidis is what we're actually going to look at. Now, right there it tells you you'll have outbreaks at occupational and recreational areas, along streams and rivers, and this is usually caused by moist, soil-enriched, decaying vegetation. So within that decaying vegetation, it gets aerosolized, and that's what you're inhaling, and that's how they're getting these buildings. Okay? So if you're around any of that water stuff, and you're camping, and something kicks some stuff up from some of the decaying vegetation, you may inhale it and not even realize it. Right? So there's your location and there's your cause. So who do you think would kind of be at risk for this?
Farmers. Campers.
Farmers? Not so much farmers, right? Because we're looking at rivers and streams, more so parks and people going out and people that fish, yes, right? Because they could be around some decaying vegetation by the water, right? Well, say again? Campers, exactly, campers. How about hunters? Right? That's a big thing that they do in the Midwest, right? Hunting. What about forestry workers? Right? Those guys that work out in those environments. Right? So you think about the folks that are at risk. Another reason why we ask, hey, what kind of job do you do? I'm an infantry guy. Okay. So this will kind of sort of lead us a little bit into all possibility. So out of the three that we'll talk about, the coccidio, the histo, and the blasto, the blasto is probably the least opportunistic infection out of the three. So here's your little map as to where within the U.S. it kind of covers, right? Mississippi, Ohio river valleys, right? There's Ohio's probably right around here. Mississippi goes all the way down here. Okay. Now here's the kind of cool part. 50% of folks are usually asymptomatic. 50% of people are usually asymptomatic with blastomycosis. Can they spread it?
Yes.
No. No. So at least we're confident in your answer. That's good. Okay? But the answer is no. None of these fungal infections can be spread from human to human. That's what that first statement on that first slide meant, right? Or none of this blasto fungal stuff can get spread from an animal to a human. Okay? Because animals and humans are the only two that will usually get affected with this stuff, that we're usually the final end of this fungal life. Alright? We're the dead end. Okay? So here you're going to have primary blastos at inhalation, which you're going to do. Right? Then you have acute, which is going to be clinically similar to bacterial pneumonia. You guys remember what some of those symptoms were? Fever, yes, great. What else? Malaise, fever, chills, cough. What else? Maybe some fatigue, maybe some chest pain, right? Maybe some sputum. Right? It's going to look very similar to that. Now, how do we differentiate acute from chronic? We do it by time. So usually chronic for blasto is usually greater than 2 months. Less than 2 months is acute. Okay? That's how we differentiate that acute from chronic. So now when we talk about chronic, it's clinically indistinguishable from TB. What happens with TB? What does TB look like? We'll talk about that later. But what do you think? What are some of the symptoms for TB you think? Say again?
Apical pneumonia.
What?
Some of the same symptoms we just mentioned.
Okay, some. All right, what else? Right, because we got to differentiate these things. Okay. So remember, I'm fat, I'm old, I can't see, I can't pee, and I can't climb a tree. So you got to be clear because I can't hear. Right? So what do you think? What are some of the TB symptoms? What do you guys think? Right? Old Doc Holliday from those westerns, he's coughing up into his thing. What were you coughing up? Blood, right? Okay. So some hemoptysis, probably from some TB stuff. So blasto, chronically, you may have some hemoptysis. What else? Persistent cough. Okay. What else? So when it becomes active for TB, it'll be upper lobar issues. That's when you have active TB. But I'm not going to see that, right? I'm looking for signs and symptoms. What other kind of things do you think they'll have? Weight loss. Okay. What are those really bad bee symptoms? You guys remember those? No? Night sweats, weight loss, right? Fever, malaise. Okay. So that's what this guy with the chronic issues that are somewhat indistinguishable from TB. Those are some of those signs and symptoms that they're going to have. Okay? Hemoptysis, shortness of breath, are really big ones. Right? And that's usually after 2 months. And as I told you, this is blastomycosis dermatitis. All of them, all the ones that we're going to talk about, once they become systemic, can affect the skin. The reason why I point that out with this one, it's like some of the other ones, but this one particularly just because of what it has in the name, is that you can get this 2 different ways on the skin. Okay? The primary way and the most common way for you to get this skin infection from blasto is systemic. So you inhale it, it becomes systemic in your body, and then it starts growing somewhere else on your skin. Okay? It likes the mucocutaneous areas. Okay? That is the primary way it affects the skin. The secondary way it can affect the skin is if you have breaks in the skin and you actually inoculate yourself with the infection, with the fungus, digging dirt, or messing around with decaying vegetation. Okay? Direct inoculation. That is a secondary method, but it is not a common method. That is very rare. All right? But if you do get a cutaneous version of this, whether it be through primary or secondary means, okay, you're going to end up with verrucous, nodular, or ulcerative lesions. It can be more on the face, then the extremities, the neck, or the scalp. That does not mean that that's the pattern that it goes. That means that is most common. All right? So most common will be on the face, and then the next most common will be on extremities, and then the next most common will be on the neck, and then the next most common will be on the scalp. Okay? That's what that right there means. Just to clarify that point right there, okay? And then remember that last one there, inoculated in open wound. That is a secondary mean, and that is very rare for blasto. All right? The most common is the primary inhalation method where it becomes systemic. So this is kind of sort of what it looks like. Right? This is all swollen. Right? See the swelling. You see some of the, you can call it eschar. Right? These are what we call satellite lesions all the way out here. Irregular borders. Okay. This one is another one. See the different discoloration? You can see it here, and then we have a bunch of this white stuff here with a bright red border here. So this thing has a lot of different ways that it can present. Right. It's kind of crazy. This is what we call a verrucous nodular. Okay. Probably coming from the nuchal area of his nose. Now, as we said, all of these can go anywhere in the body, especially after they become systemic. Right? Once they get in there, they cause that inflammatory process, everything starts leaking into the lungs, it gets access into the bloodstream, and then it just starts going everywhere in the body. It can affect your osteoarticular areas like your vertebrae, your skull, your ribs. Affect your genital urinary area, it can affect your central nervous system. So remember, these things can affect your central nervous system. So if you do have neurologic symptoms, you really should do a lumbar puncture, right? But, because this is fungal, toxoplasmosis is also fungal. We have to make sure that there's no mass effect going on in the brain. Because if there's increased intracranial pressure, you should not do a lumbar puncture. Okay? Just be aware of those. And there at the bottom it says, look, it can affect almost any other organ. Alright? So the sooner we can figure out what this is and treat it, the better off your outcome's gonna be. Because if we let this stuff go, like some folks don't go see the doctor, treatment itself is gonna be a little bit rougher. Right? So culture for this is the gold standard. Okay? If you do some microscopy, this right here, I don't know if you can see that there, that is what we call broad-based budding yeast cells. Right? You can see it over here as well. So if you get a lab result back and it says you have broad-based budding yeast cells, your first thought should be blastodermatitis. Okay? That should be a hint that that would be one of the results that you may get back from the lab, right? And here's a couple of other things that you can do, right? Diagnostic-wise, you can use potassium hydroxide or yields yeast cells. But remember that culture is the gold standard. The problem with the gold standard in this, as yeast and fungus, is that it's going to take time. It's not a 48, 72-hour turnaround like a lot of other things are. Okay? This can take anywhere from 1 week to 5 weeks. Okay? So it's going to take you some time. So you will probably be treating empirically, which is why a lot of these fungal issues like this, we usually look at clinical presentation, and then we start treating. All right. Now remember, this culture is kind of important, right? Outside the body, it'll look like a mold. Inside the body, it'll look like yeast. But you're pulling it outside the body, so it's going to probably change eventually. Okay? Now, this is a inhalation thing, right? So we need to make sure that we tell the lab, hey, we're thinking of it possibly being blasto, all right? Because they have to take precautions on their end, right? Especially when they're inhalation issues. All right, there's some issues with serology. Okay, usually you have a window at the very beginning of these fungal infections. It could be anywhere between 1 to 2 weeks. Okay? It could be anywhere between 1 to 2 weeks, whether you draw some serology, whether or not it'll be positive or not. Right? Because your body may not have developed any IgG or IgM, right, for this, depending upon when they're showing up to see you. Right? So remember, 1 to 2 weeks may or may not have some of this stuff. We don't do this. We don't do any skin tests anymore. A long time ago they used to. We no longer do that. It used to lead to a lot of false positives. It had reduced specificity. I think it's off the market now, so I don't even think FDA has an approved antigen skin test for blasto anymore. Just because it was just not very specific. Okay. So no more skin testing for blasto. So gem stain, broad-based budding yeast cells, probably highlight that. Treatment, treat all patients. Before any fungal therapy, mortality used to be up to 90%. Right? Liposomal amphotericin B is what we're going to go with for life-threatening infections or central nervous system infections. The liposomal amphotericin B is stronger than the itraconazole. You may add or just try fluconazole, because fluconazole actually has a much better penetration into the central nervous system. Okay. Here, we're going with liposomal amphotericin B because it's a lot stronger. But, just FYI, if you do have a neurologic patient with some blasto and you're not getting anywhere with that liposomal amphotericin B, you may want to try the fluconazole, just because of its penetration into the central nervous system. And that's all pharmacology stuff. But if it's mild to moderate, what you're gonna really use is itraconazole or fluconazole. And as you can see there, it's a long time that they're gonna be on that medication. Anywhere between 6 months and 12 months. Okay? Fungal infections are hard to get rid of. Okay? Things are rough. Okay? How do you say that word? All right, so now you know how I feel. Yes, ma'am. I'm sorry, I can't.
So for itraconazole and conazole, you said that those two are disseminated, or can we use this for disseminated to the
So the question is, can you use liposomal amphotericin B for disseminated?
Yeah.
So liposomal amphotericin B is specifically for disseminated. All of them are disseminated. When you have a really bad outcome, or when you have central nervous system infection already, it's already become disseminated. Yes, we can use all of them for disseminated stuff. It's just, it depends on how severe the person is, right? And that's where it comes up to you, as a provider, to do your HPI, to do your physical exam. How does this patient present? What does he look like? Is he like not breathing well? Is his SpO2 7 at 85? Does he have chest pain? Short breath. Right? The worse those symptoms, probably the worse that dissemination has gone. Right? So you may want to use something a little bit stronger. But most of us that are usually healthy don't usually get too bad. Usually we fall into that mild to moderate case. And usually itraconazole and fluconazole usually work very well. All right? Does that answer your question? Okay. Anybody else? So we got to that word, right? Coccidioidomycosis. Okay. So here's the location. It's also known as San Joaquin Valley fever or valley fever. Okay, so there's a bunch of different names that you can call some of these things. Okay. So Coccidioides immitis or Coccidioides posadacea are the two main culprits here. We're not going to worry too much about posadacea, but we're going to concern ourselves with the immitis. Okay. Here's the endemic areas within the United States. You need to know those because that's the area that I'm going to put you in for your scenario. Okay. It'll either be Arizona, Central California, Southwest, Southern New Mexico, and West Texas. Okay. New Mexico is one of the highest issues with IV in the country. Right? So you will see a lot of New Mexico. Right? So this one is highly infectious. You only need one spore. You only need one spore and it'll infect you. It'll take longer because it's got propagated in your lung and inside your body, but it only takes one spore. This one goes to biolevel 3 and biolevel 4, which is one of the reasons why you're like, hey, I think this guy has coccidio, and you tell the lab, because the lab, depending upon where you're at, usually can't handle this type of culture. Okay. So be clear. Now, as you can see there, you have worse outcomes for Filipinos in pregnancy than women that are pregnant. Okay? So in cardio, you probably saw certain ethnicities have issues with some of the medications that they use. Here, we're going to see certain ethnicities have more problems with some of these disease processes. Okay? And like I said before, they think, keyword think, right? We don't have a 100% mechanism of action for some of these issues, right? They think there's a genetic basis for susceptibility on the Filipino side of the house. For pregnancy, on the other hand, it kind of alters the maternal immune system, and it kind of potentially increases fetal vulnerability. Right? So if the mom's immune system goes down, right, the baby's susceptibility goes up. So that's what they think about with pregnancy. Okay, so here's your map. That's the entire Southwest U.S. All the way down from California to the tip of Texas. Okay? And this is where we say, hey, depending upon where you work, is what's going to be most common for you. Okay? So if we're going to work in the Southwest U.S., we know that coccidio is probably one of the more common infections that you may or may not see. Okay? Anybody from California? Yes, okay. You guys familiar with this little region down here? Yes, no, maybe? Okay, no? All right, so all these little green area here are correctional facilities. All right. I've never been there. I went ahead and did a Google shot. High desert. Tons of sand everywhere. Coccidio's in the sand, endemic. So as that stuff blows, you got a whole bunch of people in one little area contained that's inhaling some of that stuff. Right? So that's one of the reasons that little area down there is pretty high for infection. It's one of the highest areas in California. Okay, southwestern U.S., 150 cases annually. Greater than 60% happen in Arizona. All right, so greater than 60% happen in Arizona. And there it tells you high risk and incarcerated personnel in Central California just because of the location that they're in. All right. So who do you think is most at risk for this? Okay, let's think about who hangs out in the desert areas, right? Aside these prisoners in California. All right. Who hangs out in Arizona? Arizona. Yes. That is correct.
You get just like hikers.
Okay, retirees, all right? So we have what we call snowbirds. You guys know what those are? Yeah, right? So snowbirds are usually an older population, right? And what's usually higher risk for almost everything? The older population, right? So they spend their summers in the Northeast and they spend their winters in the Southwest. Okay, so snowbirds are an at-risk population. What else? Immunocompromised all the time. There's probably a bunch of golfers down there, yes, but they are not at high risk. I'm going to say the older folks. And they're inhaling some of the sand stuff, where it's endemic in the sand. That could be a thing.
Smokers?
Smokers are always at risk for inhalation type stuff. But I think about archaeologists. Okay, there's a bunch of archaeologists digs down there. Right? There's a lot of fossils found down there. There is some farming down there. Okay? Not necessarily the green corn farming, but more cattle type stuff. Right? So what about the construction workers that are out there? So you have to try to think of the folks that are most vulnerable in the areas as to how they may or may not get this disease process. Okay. Okay, so here's some signs. 60% of these guys are asymptomatic. That's freaking wonderful. Right? Most of those guys are usually us. We're healthy folks, we're asymptomatic, we got it, our body takes care of it, it goes away. Wonderful. Right? But just like the other one, the initial presentation is going to be like it's acute pneumonia. Right? There's all your symptoms. Cough, pain, fever, headache, fever, chills. All right? Big difference for this one, and I want to highlight that, would be the hilar mediastinal adenopathy, which we'll probably see on a chest x-ray, and the associated urethral multiforme or nodosum. You guys remember what that hilar mediastinal adenopathy is, right? You got that lymph nodes all around your sternum, and as that stuff continues to spread, it goes there, and then when you get a chest x-ray, it looks wide on chest x-ray, okay? That's what that is, okay? And then you have the associated multiforme and nodosum. Okay, the multiforme is a red rash that pop up anywhere on your body, okay? But then the multiforme nodosa usually pops up on the areas of bone, okay? So usually your forearms or your shins. Okay? And all they are little nodules that usually as they pop up on the skin, they usually turn a little red. They're very tender, and when you run your finger over it, you'll feel like a little bump. It'll be whoop. Okay? The most common areas will be on the forearms here, because you have that bony prominence, and on your shins, which is the most common area on your shins. And then you got your chronic pneumonia there, just like the other one. It's going to end up looking like TB. Right? Okay, so here's your secondary dissemination. Once it's gone through the body, right, gone through the body, it's going to go everywhere else. With this one, it can cause fulminant problems. Fulminant problems means it can kill you. Okay. Whatever it gets to, whatever organ, which includes your lung, right? When it gets to that point, it can be a point of lethality. Okay. So this stuff, once it gets there, it can kill you. This one's pretty rough. And there you can see the most common is usually the immunocompromised, right? Always. Right? But then here we also have high risks for Filipinos, pregnant women, and African Americans. So we have three specific populations besides the immunocompromised that are at high risk for coccidia. And so whenever you see these, have to put them at a higher tier because they are at higher risk. And then this thing, just like the other one, can go everywhere. Skin, bone, vertebrae, meninges. If it makes it to the meninges, you're going to start having some central nervous system symptoms, just like the other one. Okay? So keep those in mind. This is some of these things look like. This is a healing papule. Okay, these are what we call satellite lesions out here. Okay. This is a circumferential, very symmetrical lesion. Okay, if you look down here, see these little red spots? This is what we call nodosum. So if you were to run your finger over this, it'll be like a little bump. Okay, and when you push on that bump, it hurts. It hurts them quite a bit. All right. And then this is just a wet ulcerated lesion with irregular borders. Okay, this is something affecting the skin. Can anybody see where the problem is? I know there's no positive arrow there, but right? It'll be pretty obvious right here, right? This thing actually destroyed the bone. Okay? Destroyed the bone in this finger. Okay? It looks like the middle of the leg being considered. Okay? So these things do cause some serious damage if you just let them go. Here's the testing that you can do. You can do direct smears. When you do your direct smear, basically from the sputum, you can see some of the spherules, possibly. All right. Remember, this is highly infectious. So when you tell the lab that this is what you're looking for, you're not going to get this back. You're not going to get this back pretty fast. But when it gets to wherever it's going, so that they can actually do the culture for this one is actually rather quickly. It could be anywhere between 3 days to 2 weeks for this culture to grow out. Okay? So this one's just a little bit different than the other ones, but it is highly infectious, but it will come back a lot faster than the others. But regardless of any of those points, you're still going to empirically treat it. That's what you think about. All right? Just because of the amount of time that it's going to take for your answer to come back. Okay? Now there, we talked about the arthrochondria. Okay, the mitochondria is the little barrel-shaped thing that sits outside in the soil. Okay, when I kick it up, that's what gets put up in the air, and that's what you're inhaling. Okay? That's what that is. That's where your spherules come from. Okay? And those are microns in size, so you don't even see them. Okay? And then you got your serology. Remember, 1 to 2 weeks. All these fungal ones are the same. You have 1 to 2 weeks before your serology stuff pops up positive. So depending upon when they show up to you, if you choose to do serology, is to whether or not serology is going to be positive or not. Okay? So just keep that in mind if you're going to use serology to figure out whether this person has coccidioides or not. Okay? A lot of these things are clinical, physical exam, HPI. And we're using all this other stuff just to verify what we got. Because once we verify what we have, we can definitely make sure that the plan that we're doing is going to hopefully work. Right? And just like the other one, the skin test, there is a skin test for this one, but it's still not reliable. It kind of crosses with all the other ones. Gives you a lot of false negatives. So nobody really likes to use this thing. It actually went off the market for a while. And then the FDA, I think in 2014 or so, approved it again, so it's back on the market again. Right. But most folks don't really like it just because it's not extremely reliable. And it gives a lot of, especially early on, it gives you a lot of false results. All right. So this is what your mitochondria looks like. You got 2 different phases. There's your saprophytic phase and your parasitic phase. Right? Parasitic phase will be inside the body. Saprophytic phase will be outside the body. This is what your mitochondria looks like, right? Little barrel shape. They usually go into filaments outside. They break really easy. All right, once you inhale it, when it becomes a spherule, within the spherule, as it gets hotter and hotter, it develops those endospores. And those endospores eventually get released into your lungs, and that's what continues to propagate and cause you the problem. And see all this desert area, it just lives in the soil. Then kick that stuff up and you can inhale it. So that's your 2 distinctive phases. You have your environmental phase outside the body, and then you have your inside the host parasitic phase. Okay, so for treatment, acute pulmonary, no antifungal therapy required. Symptomatic treatment only. Okay. Other pulmonary and disseminated issues. Severe issues, liposomal amphotericin B. Moderate issues, fluconazole and itraconazole. Okay. If you have meningeal issues, you're gonna end up being lifelong fluconazole. Okay. You're gonna do IV amphotericin, but you're gonna be on fluconazole for the rest of your life. Okay, questions on that? No? So it's kind of nice with liposomal amphotericin B, and I think we mentioned some of this stuff a little earlier. It's kind of surrounded by liposomes around the outside portion of the amphotericin, and this is more pharmacology type stuff. Okay. Standard amphotericin B is very nephrotoxic. It kill your kidneys. This one is not as nephrotoxic. It's a lot stabler and it's a lot safer, especially with folks that have comorbid conditions, if it's including kidney issues. Okay. So liposomal amphotericin is definitely much better. It's got fewer side effects, and it's a lot safer because you can also increase the dose. Versus standard amphotericin, if you increase the dose, you are more than likely to definitely kill that kidney. Okay. There's just some things to keep in mind when doing this. All right, let's take a break. Today we have a little bit of this next one we're going to talk about is histo. It's Darling's disease, also known as Darling's disease, because Samuel Darling, which was an American pathologist back in 1906, discovered this as the first person to do it. Histoplasma capsulatum is the fungus that we're talking about. This is worldwide. Here in the U.S., it is Ohio, Mississippi River Valley. This is also a dimorphic fungus. Things to highlight, this Mississippi and Ohio River Valley, but starlings, which are birds, fat droppings, chickens or other birds, they drop the droppings in the soil, and the soil gets kicked up, and you inhale that stuff, and that's what gets you sick. So highlight those, because that's what you need to see inside your scenarios. And stuff grows in soil. For some reason, this one is really specific with smokers. Okay, smokers already have a decrease of cilia action, everything's really pushed down because of the nicotine tar, which makes it more vulnerable to most infections, not just this one, but for some strange reason, this one really harps on smoking. Who do you think is at risk for this? Okay, there's your spunkers, right? Okay, for those of you who don't know what spunkers are, those folks that like to go in caves. Alright. Who else? Okay, bird farmers, chicken farmers, right? Because this thing says chickens and bird droppings. Alright, so there's your at-risk folks. There's your distribution of histo across the U.S. Right. Here's a bunch of bats that poop all over the ground. And people usually walk through the bird poop or the bat poop when they go hiking through caves or spelunking. Okay. We have acute pulmonary issues, mild to self-limiting, 95% clinically inapparent. Okay. If it looks like you got the flu, usually you get better. Okay. You have that small percentage that really gets sick. And here you got hypermetasinal diagnostic, just like the last one. So if I do a chest X-ray on this guy, it's going to look just like the other one. Okay. But this one is also going to include some patchy infiltrates, which should be a little bit different. Okay. This one can have chronic cavitary lesions, which are for chronic. So for this one, greater than 1 month is chronic. And what cavitary lesions mean is that once this thing gets in there, it can cause granulomas. Okay, and we'll talk more about this when we get to TB. But granulomas are an organized collection of a bunch of immune cells that are trying to kill this thing. A lot of the problem is that it can't kill it. So what it does is it just surrounds it. Okay? It surrounds it and balls it all up and keeps it in there until it either dies or until it breaks free. Right? So that's what a granuloma is. Now, if it does break free from a granuloma and it does get onto the tissue of the lung, then it creates what we call a cavitation. And all that means is that the histoplasmosis is actually eating away at your lung tissue. Okay? So it's creating a big cavity, it's creating a big hole in your lung. Right? At that point, it can get into your vessels, it can do all this other crazy stuff, right? But once it gets into your vessels, then it becomes systemic. Right? Now it's going to spread all over the place in your body. Right? Localized, all that means it usually happens through direct, it can happen through direct inoculation. Okay. This one also has that cutaneous aspect, just like the last one does. This thing can be stable or progressive. Okay. Stable meaning it's not getting any worse. Progressive means once it gets in there and starts affecting you, it's going to get worse. Okay. So either way, from the localized infection, you can get worse. Cutaneous means that you have that cutaneous infection because you put your hand where it's not supposed to be, or whatever open sore. Right? And disseminated is once it gets into your lungs and once it breaks through and causes that cavitation, or gets into your vessels in some way, shape, or form via your lungs, it's going to disseminate all over your body. Now, this one usually likes immunocompromised folks, just like it likes the smokers. So here it's going to tell you low-grade fever with the immunocompromised folks because their body just can't handle the problem. So unlike you getting a regular fever, you're going to have a low-grade fever with these immunocompromised folks. You may have some weight loss, but then you may also have some anemia. And that anemia is because it may inhibit some of the bone marrow from making red blood cells because of the cytokine inflammatory reaction that it's causing. Right? Remember at the very beginning we told you, hey, you're inhaling, we're not going to worry about all the black box stuff, but it causes a cytokine inflammatory reaction. That cytokine inflammatory reaction disrupts some of the iron metabolism that occurs within the erythropoiesis segment of the bone marrow. So these guys may end up having some anemic type effects. And that could also cause oral lesions and cutaneous lesions, right, because it can affect the skin. Right, here there's cutaneous histo lesion. Okay. So I like this slide, so keep an eye on this slide because when it gets out, right, when it becomes systemic, and you can look at the area that it's affecting, right? This is the cause. This is what it's going to end up looking like. Right? This is the manifestation of what attacking the adrenal glands is going to show you. So this slide is good to tell you if it does get out and it's attacking certain systems, what that system's going to end up looking like once it starts getting attacked. Okay. So here's a whole bunch of symptoms and things that it can look like when certain areas get attacked. So this is a pretty good slide. Okay. So here's some test diagnostic studies, direct smears, sample from sputum, tissue, bone marrow. Usually we don't do bone marrow because that hurts a lot. Okay, very invasive. But if you do the gym sustain from sputum or tissue, you're going to get narrow blood MDs, which is completely opposite than the other one, which is broad-based. This one's narrow. You don't want to necessarily depend on this culture. This culture could be anywhere between 2 to 6 weeks. And just like the other ones, this one's dimorphic, so depending upon where you have it is what it's going to look like. Remember, for serology, just like all the other ones, you have a 1 to 2 week window, right, where your serology may not pop up positive. So just keep that in mind. You can do some antigen testing. That's usually pretty good for this one. Okay, so the antigen testing down here with blood and urine. So treatment-wise, acute pulmonary. 95% of these guys usually get better, right? So you may not even need to treat. But if you are going to treat, okay, there's 2 specific things that you can look for. If they become hypoxemic, right, if that SpO2 is dropping in your patient, you probably should treat. Or if it's gone beyond 1 month that they've been sick, go ahead and treat. Okay. Key. Now, if you have severe or some other life-threatening issues, liposomal amphotericin B, okay, just like all the other ones, and then mild to moderate, itraconazole. So we really haven't deviated from any of these medications for any of these, right? So kind of easy to remember, right? And there, for AIDS patients, you'll probably treat with liposomal amphotericin B because it's probably going to end up being severe, but they're also going to have lifelong suppression with itraconazole. Yes, sir. For the testing? For this one? Yeah, usually the antigen testing, the blood or urine. Okay, so I kind of like the slide because it tells you whether you should treat or not treat if you have any of these other symptoms. If it's become systemic and it's attacking other areas of your body, right? So acute or symptomatic, right? Self-limiting flu-like, not indicated. If it is acute pulmonary and you do have some hypoxemia or it's been greater than a month, then just go ahead and treat. Right? And you'll treat them as mild or moderate with itraconazole. And then you have all the acute pericarditis. You would treat those as mild to moderate or severe depending upon how the patient presents, what kind of symptoms they're actually having when they present to you. Right? Questions on this slide? Okay, crypto. Okay. I would highlight associated with physiodromics. Alright, Cryptococcus neoformans. Neoformans. Okay. Worldwide distribution, it's everywhere. Okay. You would think it'd be more common in the cities where we have a whole bunch of people with pigeons. But a lot of those guys are already positive for this thing. Okay. Uncommon and immunocompetent individuals. So folks like us that are healthy usually don't have much of an issue with this one. Okay. It's more common in the immunocompromised, especially when it's less than CD4 200. Okay. So this one really attacks folks with AIDS. High mortality prior to use of that hepatitis B. This thing does cause you meningitis, especially because it's affecting the immunocompromised. It gives them more of an infection, right? More possibility of a worse off infection. Here's your meningitis and meningoencephalitis. Right? It could be subacute or chronic, right? So it can be slow. Take its time before it actually develops any of the symptoms of meningitis or meningoencephalitis, or it can be chronic. They can have it for a while, and it's just you're going to have it for a long time until you start taking care of it. Right? Without therapy, these guys die. Right? Because these guys are going to be the ones, the immunocompromised patients are going to be the ones that are really going to be dealing with this versus the health patients. If you look at all those symptoms down there, they're all neurologic symptoms. They're all neurologic symptoms. Okay, so here's some pulmonary crypto issues. Okay. They can be subacute to ARDS. You don't know what ARDS is, it's acute respiratory distress syndrome. So it can be really, really slow. Right? You have 5% of people that can usually get bad with this. And with them, it'll just start developing on until it gets to a point where they have to come see you. And a lot of times, if they don't come see you early enough, they'll end up already in ARDS, which means you really need to put them into the hospital, into an ICU, and you probably should be intubated at that point. So you have to be careful with those folks. Right? These guys present usually with those acute pneumonia type symptoms that we talked about. Right? This one also has the cutaneous manifestations just like the other ones. Just understand that the cutaneous manifestations for all of these, the primary way that happens is via the lungs and then systemically, not necessarily direct inoculation. Right? And then this one, just like all the other ones, can affect a whole bunch of different places. Here it's telling you other sites will be the prostate or the mesenteric cavity of bones. Right? So there's a whole bunch of different places this can affect. Okay, these are what we call umbilicated non-necrotic lesions that are well circumscribed. Okay? Or circular. The reason why I tell you those terms is so that you can start hearing them, so that when you make it to dermatology next semester, you have heard some of these terms. So when they ask you to describe some of the things you'll see in derm, you'll have some words that you can probably just go out there. Okay. Test agriculture. And some of the better ones would probably be the direct microscopic exam on smear. From there, that'll usually reveal some yeast cells. Okay, if you do it that way, those things usually look round, oval, with clear halo shapes. That's usually what those things show. You can do the India ink. The India ink will usually do a halo effect on them. If you do the use of caramine stain, that'll be red or pink. That'll confirm the presence of a fungus. All right, remember the 1 to 2 weeks prior for serology. You can use that later on, especially for dissemination. Because by the time it disseminates, these guys have had it for greater than 2 weeks. And then you can do some radiology shots here, specifically before we do any kind of lumbar puncture, right? Because we don't want to make things any worse. Right? There'll be that intracranial pressure before you actually do that lumbar puncture. Because if you do have intracranial pressure, then you don't need to do a lumbar puncture. Okay? And radiology doesn't tell you what this thing is. Radiology can show you some things, but it does not define that it is a fungal issue. It does not define that it is crypto. So radiology is not going to help you determine whether this is or is not cryptococcus. Okay, if you look at these little things out here, this is that halo effect that we were talking about. Okay, clear halo around them. Okay, treatment, immunocompetent. Okay, for pulmonary issues, it'll be fluconazole. Central nervous system issues, it'll be. So this is the only one that's a little different. Okay, this one will be CNS issues, central nervous system issues, meningococcal, meningoencephalitis. You would use liposomal amphotericin B with flucysteine. So this one's the only one that's a little different than some of the other ones. Okay. As for the immunocompetent folks, right? So the immunocompromised will be the same match, same condition. But those guys will be on fluconazole for the rest of their lives. Okay. Here we're going to talk about 4 different specific fungi. Right? All of these target immunocompromised people. Okay? All of them. That's what they do. The parococcidiomycosis, that one is very similar to the coccidiomycosis that we just covered. That one likes to target farmers and residential areas. Okay, these are all worldwide. Parococcidiomycosis is more so in South America and Central America. Mostly they're just the Latin countries. Okay? And then penicillinosis is usually in Southeast Asia and Southern China. All right. But the other 2 are generally worldwide. Out of these 4, zygomycosis, okay, or mucormycosis is the other name for it. That is the newer name for it. Is probably the worst one out of all of them. Okay. And that fungal infection affects the palate. It affects anywhere in the body, right? It's inhaled. But it likes the palate and it likes the plate right in your nasal area that leads right to your brain. So this one causes a lot of encephalitis and meningitis. Okay? And you can see the folks that it likes to attack specifically, but this one really, all of them attack the immunocompromised, but that one specifically is the worst out of the 4. Zygomycosis. The other name for that is mucormycosis. That is the newer name that they use for that same process. These names change all the time whenever they find something a little bit different. They just go ahead and change it. So that's another name that they can possibly use for that. Okay, candidiasis. Okay, there's a whole bunch of different candida species. Candida albicans is the most common, that's generally the one we're going to talk about. It is a common flora that we have in our GI tract on our skin, within the vaginal area. It is common. We usually have it. Okay, the non-albican Candida yeast. Okay, there's some other species, and some of these other species are associated with other issues, right? So tropicalis is usually associated with malignancy issues. Okay. Cruci is resistant to fluconazole. So if we have that one, we know fluconazole is one of the standard things that we use to treat candidiasis with, but if it is that specific species, then we have to figure out what else can we use instead of that. And usually it'll be the echinocandidase is usually what we'll use. Paracillosis. TPN is total parental nutrition. For those of you who don't know what that is, that's a feeding tube. Someone has to be fed with a tube. Okay. Problem with that is if that tube stays in too long, it may grow some candida around it. If it grows candida around it, it can get into the system and then it can become systemic. Okay. So we have to kind of be careful with those things. If you want to talk probably the worst one, would probably be the Lusitania, okay, because it's amphotericin B resistant. Okay, and you know amphotericin B is like one of our big hitters, right? Broad-based, does a lot of things, but it's resistant. So we have to look at some of our echinocans now to fight against this thing if it doesn't, if it's resistant. Okay. And then Galbrata, same deal, causes urinary tract infections, but we have realized that it is fluconazole resistant, so we have to try some other kinds of medications. Okay. And for that one specifically, usually we'll use the different amphotericin. That one we'll use the amphotericin dioxide. That one gives you a high concentration in your bladder, okay, and in your kidney area, which allows it to kill the candida. Okay, so here's a whole bunch of different things that you can look at that candidiasis can present at. Okay. Thrush is a huge one. If you see thrush in a young kid or a young person, the first thing you should think about is AIDS. Okay. Young people, barring they're not asthmatics, should not have thrush. If they have thrush, something's going on, one of the first things you need to think about is AIDS. So you should do an HIV test on it. Okay. If you see thrush in a young kid. Esophagitis, irritation of the esophagus due to candida, probably being swallowed. Intratigo, little baby fat rolls. Is that cute? Little baby fat rolls, cute, right? Right? So within those little baby fat rolls, you can get candida that grows. So it'll get really wet, red, and it'll get little white, moldy, yeasty looking things inside of it. That's what intratigo is. Okay? Vaginitis, okay? We'll talk about that in a bit. And then onychomycosis. That is one infection of your nails, right? If you're going to do, or if you suspect that that's what it is, do some scrapings of the nails, send that off to the lab, make sure you do LFT on the patient, and then you can go ahead and prescribe them the medication. Because the fungal medication that you're going to use for that is processed through the liver. Okay? And then you got two other ones, your Fuguria, that's fungus in your urine, and then anemia, candidiasis in your bloodstream. Okay. So usually you'll see some of that neonates, diabetics, and antibiotics. Okay, let's not forget antibiotics are indiscriminate. Antibiotics are indiscriminate, they kill everything, okay? To include the good stuff that's inside of our bodies, right? So it can cause folks to have thrush because it allows it to overgrow. Okay? So let's not forget that specifically in females, okay? Especially for the vaginal floor. Obviously the immunosuppressed. Okay, so for those of you who are going to be taking care of asthmatics, there it is, what we call a spacer. You guys know what that is? Did they talk to you about that in farm? No? A spacer is just a little tube, okay? About yay long, just a little tube, right? So what happens is we try to teach kids to take their inhalers appropriately, right? Shake, shake, shake. Okay? They need to be perpendicular so that the opening shoots straight to the back of their throat. A lot of times they just shake, 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 and they'll angle it where the opening goes to the roof of their mouth or to their tongue. Okay? And what do steroids do? Steroids allow other things to happen. Okay? So it causes some of that thrush to overgrow, which is why we give them the spacer. We attach the inhaler to the spacer, and the spacer usually goes straight to the back of their throat. Okay? Giving them a better angle instead of doing this when they're inhaling their steroid inhaler for their asthma. Okay? And there it tells you, always think HIV in young adults if you see thrush. Okay? That is, you should not be a young adult and have thrush. Something's going on, you just need to figure what that is out. Esophageal disease, they're immunocompromised patients. You'll have, difficulty swallowing, painful swallowing. Okay. You guys know what trouches are? Did they talk about that in farm? No. Those are lozenges. Those are lozenges that we give folks. We allow them to dissolve and they can swallow it to treat thrush. We also have the swish and spit to swallow the statin to help take care of some of those antifungal issues as well. All right, there's some white patch of plaque on the tongue or on the roof of their mouth. Okay, sort of look like that. These things can be painful or painless. All right, depends on the severity. Here's some more. This is generally what the culture would usually look like when you have candida, because they're just those spots that start growing out. That's candida down the esophagus. Okay. So sexually active females can usually get candida. Okay, it's a thick white vaginal discharge. Pregnant women can get candida. Mostly because they start having a higher estrogen level, which causes more glucogen. So it allows candida to thrive. And with female pregnancy, usually we'll do topical clotrimazole or menconazole. Both of them are category B, okay, which makes it safe for pregnancy. Then, of course, diabetics, right? Because their system is just completely out of control. They're out of whack. And don't forget, anyone taking antibiotics, right? For most cases, when women come in and complain of vaginal candidiasis, you can ask them, have you had this in the past? Sometimes they'll tell you yes. What have you taken? And they will tell you. So they're giving you the answer sometimes. You just got to ask the right questions. Right? And usually we don't send stuff out to the lab unless we have to, but these are usually done empirically and we just give them the medication that we need. In most cases, it's usually just a single dose of fluconazole and we're good to go. Okay. So, you guys remember your AMSO criteria? Smell fishy. Right, so it's positive. What else? pH, right? pH greater than what?
4.5.
Greater than 4.5, right? Okay. And what else? Okay. Thin, white, homogeneous discharge. Okay. And then obviously clue cells. Right? When we see clue cells, it's like, oh yeah. But here, your pH is going to be within normal limits. So if you decide to take a litmus test, piece of paper, and try it, it'll be within normal limits. Okay? It's not thick. It's not thick, it's usually thicker. Right? So right there, 2 of the 3 of the AMSO criteria are not met. Right? And then if you do send it off to the lab, you're going to get oval-shaped bunny yeast or pseudohyphens, which you're going to possibly get, which is completely different than clue cells. So you're already not meeting AMSO criteria, so it's a good way to differentiate this from that. Okay. Vertigo usually, right, those most of the skin cells, you'll see that on obese people and you'll see it on babies, right? Their skin rubs together. It's a great place for it to build up, right? Dark, moist places. Right? Usually those nystatin or other powders are pretty effective with preventing. Okay. They may present similar to tinnitus, any of the tinnitus. And usually we'll just get some resolves, and that usually helps. Okay, this is a little baby with a vertigo, Canada in their neck. Okay, the little white stuff there is Canada. But look at how red everything else around it is. So all that redness is really tender. Okay, this is onychomycosis, right? So we usually give Lamisil for this. Take nail scrapings, send it off to the lab, and do LFTs, right? Because the Lamisil is pretty strong and gets processed through the liver. We need to make sure the liver is good, okay? All right. So funguria. So typically this is nosocomial, so you'll have this, you'll get this when you're in the hospital, all right? And usually it's from being catheterized multiple times or having a catheter placed for a long period of time. But the stuff usually colonizes inside the bladder. Or you'll be on antibiotics for a longer period of time, and the same thing may happen. Okay, so here are some risk factors for systemic infections. Okay. Surgery, antibiotic therapy, okay, parental nutrition. So you can ask all these questions of your patient when you're talking to them, right? You'll know whether they're immunosuppressed or not. You'll know whether or not they've been using steroids for long periods of time, right? A short course is not going to make it that bad, but if you're on steroids for long periods of time, usually it's when it gets bad. Okay? So you'll know a lot of these answers, especially these down here. Okay? The big one that we always forget is this antibiotic therapy one. And then candidate systemic fungal. So this is more of a stats slide here, but look at these numbers for outcomes of candida bloodstream infections. 35% of them survive the hospital. Right? 30% of them die of the underlying disease. Okay? But 35 of them die because of the candida infection. Right? So if you do whether the underlying disease and candida infection, that's 65%. And that's a pretty good number that we could actually address if we catch this stuff sooner rather than later. And then you've got systemic deep and disseminated. Right? Systemic just means that it's not in one place. It's all over the place. Right? It's been distributed throughout the body. Right? It's gone beyond the initial infection site, whatever that may be. Okay? Deep just means that it's gotten into the tissue. Okay? Whether it be organs like the brain, the liver, kidneys, whatever it may be. That's what deep means. And then disseminated is just spread throughout that bloodstream. Okay? So that's what that means, and usually when it's that way, disseminated throughout the bloodstream, we have a higher mortality rate. This is pretty bad, some bad stuff. Right? Especially initially because it's really difficult to diagnose, right? Because you're going to present with fever, cough, sometimes weight loss and fatigue. What am I going to do with that? I don't know. I have to do a whole bunch of workup for that. So that's usually what takes so long sometimes in figuring out whether you have a disseminated candidal issue or not. Right? And you're going to have to start doing a whole bunch of specialized testing at that point. Do anything from fungal cultures to biopsies to PCR, a whole bunch of different things. So here, testing-wise, this is usually made by clinical findings and history. Right? It's really hard to figure out what this is. So we'll use all these other labs and direct observations to try to help us with that HPI and the QRST that we're looking at. We can usually diagnose it by cultures. Okay? But sometimes we'll use the GMS. Okay, GMS is gonorrhea, methylene, silver. You guys don't have to worry about that stuff. That's all stuff that's going to happen in the lab. But if you use GMS, that's going to turn the stuff black or brown. That's going to define whether or not it is fungal or not fungal. Okay? And then PAS, you should probably know that PAS one has a periodic acid shift. That one's really common. And what that one does is it turns the stuff either magenta or pink, right, on the slide, and it detects fungus or bacteria. Okay? But that's stuff that'll happen in the lab. You don't have to worry about that. Now the yeast itself, when you look at it in the culture, it's going to either form hyphae or pseudo-hyphae, because that's what yeast looks like, and that's what it does. Okay? Now, usually we'll do the culture as the gold standard, but blood culture specifically for candidemia is the gold standard. Right? Now you're taking blood, candida's in the blood, and you're going to grow out the blood. That's generally the gold standard. All right? That germ tube function, it's a rapid and reliable test, and it can differentiate the Candida albicans. It can differentiate the species so that you can actually tell which one you have, so you can make a much better plan, figure out which antibiotic you actually need. Okay? That's the nice thing about the germ tube formation. And then that usually produces a nice smooth, creamy, white colonies when it's all said and done. Serology, like I said, the other ones, not super concerned with the serology. So most infections, systemic or deep, are covered by IV lipid-based amphotericin B or IV voriconazole. Right. Now, this is where we get to the kinocans. Those are much newer. We can also use those to help here. We're going to go with what's on the slides, but just an FYI, the kinocans are usually, or can be also used for candidemia. The other thing that's not on here is the PCR. PCR is another good thing that you can use here because it'll be very specific for DNA, and it can speciate your sample. So it can also tell you specifically which one you got, so that you can really develop a specific plan based on what the speciation is. All right? Anybody have any questions? Sure. No, that's separate. That's separate. Yeah, culture to culture germination tube is a completely different test. Okay, the soil culture for candidemia would be the gold standard. Any other questions? No? Yes, maybe?